Thanks so much for ICS for asking me to speak about statistical considerations. I'm Kari Tikkinen. I'm a urologist and clinical epidemiologist from the Departments of Urology and Public Health at the University of Helsinki and at the Helsinki University Hospital. Imagine yourself as a board member of a national guideline who's deciding whether or not to fund mammography screening. And I'm a clinical epidemiologist giving you the evidence. What if I tell you that mammography reduces the rate of dying from breast cancer by 33%, and this comes from a meta-analysis with very good statistical power, p-value is small, so it's very unlikely that this is due to chance. Would you fund mammography screening or not? In my experience, most people would say yes. They would say, yes, I would fund mammography in our country. What if I give you evidence which says that mammography increases the rate of patients not dying from breast cancer from 99.82 to 99.88? And again, this is highly statistically significant, not likely that it's due to chance. Would you fund mammography screening in this case? In my experience, some would, some wouldn't. And quite many would be a little bit uncertain. What if I tell you that 1,700 women needed to be screened yearly for 7 years to prevent one death from breast cancer? And again, highly statistically significant. Would you fund mammography screening in your country in this situation? In my experience, most people would say no, but some would say yes. So let's take a look on these numbers more carefully. So these numbers come from a meta-analysis comparing screening or no screening for breast cancer. If we don't screen, there will be 18 women dying from breast cancer out of 10,000. And if we do screen, there will be 12. If we want to calculate so-called relative risk reduction, we will calculate so that it's 0.18% minus 0.12% divided by the baseline risk, which is the risk of those not screened, in this case 0.18. And then we will give this relative risk reduction of 33%. This is the number what you were saying, most of you were saying that I would fund mammography screening. However, we can take all these numbers, a look on these numbers also differently. When we say that in unscreened arm 0.18% dies, it means that 99.82% do not die from breast cancer. And in the screening arm 0.12 means dying means that 99.88 do not die from breast cancer. So we can calculate also so-called absolute risk reduction. It means 0.18 minus 0.12, it's 0.06. And you can calculate number needed to screen by knowing the absolute risk reduction, which is 100 divided by 0.06, and then we will get this number of about 1,700. So all these numbers actually came from the same evidence. P-value is same for all. It tells nothing about the magnitude. You have to think about absolute numbers to get the information regarding the magnitude. Here's another example. This is from a landmark study of hypertension, so-called VA hypertension study. And these researchers, they looked mortality, so very hard outcome again. And these are people with somewhat elevated diastolic blood pressure. In the control arm, 7.4% died in 5 years, and in a treatment arm, 5.9%. So if you want to calculate the relative risk reduction, it's 0.074 minus 0.059 divided by 0.074, and you get this 20% relative risk reduction. We can look these numbers also more carefully. So this slide is from the same study. You see there's about 20% relative risk reduction in two subgroups. The other one is the patients who are higher risk of dying, those who already had a target organ damage. And then there's another group who are those who didn't have target organ damage. So in the control arm, there's a 20% risk in the higher risk patients and a treatment on 16%. So 20 to 16, it's a relative risk reduction of 20%. And in those who with lower risk from 5.7 to 4.5, again, it's about 20% relative risk reduction. But we can calculate also other things. We can calculate absolute risk reduction. That's 20% minus 16. It's 4% in the higher risk patients. And 5.7 minus 4.5, it's 1.2% in the lower risk patients. And then again, you can calculate the number needed to treat. And even though the relative risk reduction is exactly the same, the number needed to treat is quite different because of the different baseline risk. So you need to, in the higher risk, you need to treat only 25 compared to the lower risk where you need to treat a little bit more, 83. So let's do one example together. If you have a patient who already completed 6 months prophylaxis or treatment for DVT, and then you're thinking about whether he or she should continue or not, what do you have to know when you do the decision? If you are a patient and your doctor tells you that, okay, you can continue the prophylaxis and it will reduce the risk of recurrence by 33%. This is unlikely to the chance because it's based on high quality evidence and the p-value was very small. Would you be happy to continue or would you need something more? What is there actually missing? What is missing is the baseline risk. So in all these populations, population 1, 2, and 3, they all have this, what I had in the previous slide, 33% relative risk reduction. But it's quite different for different baseline risks. If we look at the first one, relative risk is 0.67, that's same as relative risk reduction of 33%. In that, when the baseline risk is as high as 30%, it's really remarkable. It's 10% risk difference in absolute numbers. Whereas in these lower risk populations, although the relative risk is exactly the same, the absolute effects are way smaller. So when you think about relative measures, you may have different kind of relative measures, such as relative risk reduction, odds ratio, relative odds reduction, and hazard ratio. Today we have focused on relative risk. Let's do one more example together. So think about you as a physician, you have a patient who is a 65-year-old man, has a COPD exacerbation, likely not walking in 3 days, and you will hospitalize him. Again, randomized trials show that using thromboprophylaxis decreases the risk of thrombosis by 50%. Would you prescribe thromboprophylaxis for this patient with this information? Or is there some information missing? Yes, we need to know the baseline risk. If I tell you the baseline risk is 4 out of 1,000, would you? Then what I suggest you would do, you would think about how big is the difference. So with baseline risk of 4 per 1,000 and relative risk reduction of 50%, the risk difference is 2 per 1,000. So you need to prescribe thromboprophylaxis to 500 patients to prevent one thrombosis. And because we know treatments have also harms, this is not necessarily in favor of treatment. But what if I have a patient who's 65-year-old, he has disseminated cancer, now he has severe pneumonia, and he's also likely bedbound for 3 days. I tell you here, relative risk reduction is 50% again. But this time, baseline risk is way higher because it's 10%, so the risk difference is 5%, because from 10 you go to 5%, the risk difference is also 5%. So in this case, you only need to treat 20 to prevent one symptomatic thromboembolism. So this is much more likely in favor of treatment than the previous example. So in summary, there are relative estimates, there's risk ratio, odds ratio, and hazard ratio. There are absolute estimates such as risk difference, absolute risk reduction, and number needed to treat. Patients are ultimately interested in the reductions in absolute risks. They are not interested in the p-values or relative estimates in that much. Absolute risk reductions are not constant across patients, but relative risk reductions typically are. You need to get the absolute risk reductions, and you can get them if you know the baseline risk and relative risk reduction. And then you can get the numbers, which are very helpful for your own decision making and for your patients. I hope you find this video helpful.